Uh, Hello, everyone. Thanks for the opportunity. And I will be presenting the early effect of sorafenib on cognition, cardiovascular, and reproductive functions in patients with fibromatosis. So this study was funded by DTRF, and I have no conflict of interest to declare. So this slide is very familiar. And the only thing is that optimal duration of sorafenib in desmoid type fibromatosis is not known. And long-term use might lead to long-term toxicity in various systems. So majority of data comes from advanced cancers, but in renal cell cancer, it has been seen that sorafenib might cause difficulty in learning, memory, and executive functions. Similarly, there is a data to suggest that these drugs can cause hyperlipidemia, especially hypercholesteremia and hypertriglyceridemia. Hypertension might happen in almost 20% of patients. It might impair cardiac contractility and might, in patients with comorbidity, it might cause coronary artery disease. And in our unpublished data, almost 50% of ladies might end up with some menstrual abnormalities. And similar TKIs are reported to cause ovarian dysfunction. So we started this prospective study with sequential assessment of cardiac, vascular, cognitive, and reproductive functions after start of sorafenib. And whatever comes, the toxicities will correlate with dose and duration of sorafenib. So we included patients with more than 18 years with medically indicated treatment, and those people who haven't started sorafenib or are about to start sorafenib or have received within last 2-3 months, but no previous cardiovascular, neurological, and menstrual problems, and were able to perform cognitive tests. So we started sorafenib, and this is how we measured cognitive function test. First was questionnaire-based assessment. These are patients' reported outcome with FACT-COG questionnaire. It's functional assessment of cancer therapy cognitive questionnaire version 3, depression and anxiety questionnaire, and appearance anxiety inventory. We use objective assessment, CANTAP testing for attention and working memory, processing speed, sensory motor function, and neuroimaging with MRI for structural changes, microhemorrhages, and lacunar infarcts. For vascular functions, the arterial stiffness was measured by carotid femoral pulse wave velocity, which is the time pulse wave takes to travel from carotid to femoral. Aortic augmentation index, which is excellent indicator of cardiovascular comorbidity and mortality. Subclinical atherosclerosis was tested by carotid artery intimal medial thickness, which is more than 1 millimeter is pathological. And endothelial function were measured by brachial artery flow mediated dilatation, which is executed by nitrous oxide. In response to hyperemia, if nitrous oxide is adequate, then it leads to increased dilatation. Cardiac function testing was done by left ventricular ejection fraction testing by 2D echo, and global longitudinal strain was also seen, which is more sensitive in detecting earlier cardiac changes. Electrocardiogram sequentially, and along with troponin I, brain natriuretic peptide, and lipid profile. Reproductive tests were along with thyroid TSH, luteinizing hormone, FSH, estrogen, and anti-melanin hormone were seen for reproductive functions. So we planned almost 50 patients prospectively from Sarcoma Medical Oncology Clinic in All India Institute of Medical Sciences. And this was the schema used. Cardiovascular testing was being tested at every 3 months, baseline 3 months, 6 months, 12 months, while cognitive and reproductive function tests were supposed to be tested at baseline 6 months and 12 months. Every 3-monthly assessment was done for patients. And this is the statistical ANOVA test, or its non-parametric variant was used for statistical analysis. So far we have recruited 21 patients. Of them, 1 patient has progressed on sorafenib, early progression, and there is baseline data for 20 patients. Median age is 32 years, almost equal males and females. Controlled hypertension and hypothyroidism on medicine were in 2 patients. Majority of patients were extremities. And sorafenib 200 mg once a day is in majority of patients. With 200 mg twice a day, only in 21% of patients. So far, they have received 8 months of therapy. So regarding a questionnaire-based assessment, the cognition at baseline and at 6 months doesn't differ. So they are patient-reported questionnaire, and they are more sensitive how patient perceives their cognition and other perceive their cognition and its impact on quality of life. As you can see the baseline and 6-month data, there is no change in quality of life, perceived cognitive abilities, perceived cognitive impairments, and the box plots also show that there is no difference in the outcome. Similarly, the depression, the baseline depression and anxiety were high in these patients. However, with time, numerically, they decreased. This might be due to decrease in pain and treatment. However, there was no increase in depression, anxiety, or stress. With objective assessment of cognition done by Cambridge Neuropsychological Test Automated Battery, the reaction time, delayed matching to sample, spatial working memory, and motor and screening test, there was no difference in baseline and at 6 months. Regarding the vascular functions, the pulse wave velocity is gradually increasing. As you can see, the median at 6 months is 8.4 as compared to baseline 7.4. However, it's still not significant. Aortic augmentation index, the measure of stiffness, systemic arterial stiffness, carotid intimal media thickness, measure of atherosclerosis, and flow mediated dilatation, measure of endothelial function hasn't differed at baseline 3 months or 6 months. Similarly, the lipid profile, these drugs are known to cause hypertriglyceridemia and hypercholesteremia. They haven't differed at 3 months and 6 months. The blood pressure monitoring so far has the median, there is no statistically significant difference, but 3 patients had new onset hypertension, which is mostly grade 1, and we have started the treatment. Baseline 2D echocardiogram is normal in almost whatever all the patients have been tested. Electrocardiogram in 3 patients, there was left ventricular enlargement as baseline, but it was probably normal variation. However, 1 patient who had ECG baseline normal at 6 months developed sinus tachycardia along with ST segment depression in V2 to V6 and ST segment elevation in AVR. And this is the same patient who developed hypertension and increased pulse wave velocity. Cardiac markers, the troponin I level were increased in 2 patients. It was asymptomatic injury. 2D echo is normal. And it was almost 460 and 1200. So far, brain natriuretic peptide is normal at baseline at 6 months. So this is the pre-treatment ECG in one of the patients. And this is the post-treatment. As you can see, there is visible tachycardia. Similarly, in V4 and V5, J point depression is there. Along with in AVR, there is ST segment elevation. We don't know its implication, but then we are following these patients very closely. There was significant hypothyroidism, statistically significant, almost in 25% of patients. LH, FSH, E2, and AMH were comparable. Of almost 10 ladies, 4 ladies developed amenorrhea. And of them, 1 developed menorrhagia after a few months of amenorrhea, leading to moderate anemia. So other toxicities were hand-foot skin reaction. 2 ladies developed rash, diffuse rash with pruritus. However, changing of another brand led to improvement. And hand-foot skin reaction was seen in almost 76% of people. So far, clinical outcome in whatever patients it has been assessed. 23% patients have responded with reduction. Stable disease in 61% of patients. 1 patient who was progressive was shifted to chemotherapy. This is the lady after 6 months of sorafenib. As you can see, the T2 hypointensity has increased, implying that fibrosis has happened and with mild decrease in size. So this study is continuing and almost 20 patients have been enrolled and we are planning for 50 patients. No cognitive impairment so far. Anxiety, depression was baseline higher, but then it is improving. We are worried about myocardial injury as exemplified by troponin I level high at 3 and 6 months and 1 patient with asymptomatic ECG findings which were normal at baseline. Similarly, grade 1 hypertension in 18% of patients, hypothyroidism 25% of patients. So far, the hormonal profile of FSH, LH and AMH are fine, yet 40% of ladies develop amenorrhea. They are very early results. So the current questions about sorafenib that need to be answered are appropriate dosing. If we can limit the duration of sorafenib as we are discussing, and of course this drug is going to stay because a lot of places nirogacestat is not available. This is our prospective study. in which we started almost 50% patients were started on different doses, 200 mg once a day and 400 mg once a day. And gradually, a majority of patients were shifted to 200 mg once a day, and there was no difference in response rate. And this is the study which we presented last year in ESMO, and we stopped sorafenib in responding patients after 1 year of sorafenib. And we defined progression after stoppage of sorafenib, progression by 10% increase in size or more than 5-point increase in pain score. And we found that like almost at 1 year of stoppage of sorafenib, 96% of patients didn't progress as per our criteria. However, in 30% patients, pain increased, and now longer follow-up is available, and probably this year we'll be submitting the longer follow-up. So this is still work in progress, and we'll come out with all the cognitive, cardiac, endocrinological function in all 50 patients with longer follow-up. Thank you for listening, and thanks for DTRF to fund the project. Thanks to my department, Department of Medical Oncology, AIMS, Department of Physiology, Reproductive Biology, Cardiology, and my PhD candidate, Vaishnavi. Thank you very much.
Questions? Go ahead.
First of all, you should be congratulated for doing a prospective study looking at toxicity, which is not, especially on drugs that we use, but we really don't know long-term data. So I think this is fantastic. The other thing, you're obviously, I saw on your table initially, there's like multiple different starting doses for sorafenib, I believe, for some of the patients. So I assume that's not standardized, but it'll be interesting with enough patients if you could compare the toxicity between, as you mentioned, every other day dosing every day, because many of us sometimes use that other dosing because patients don't tolerate, and find anecdotally patients still do as well. And that's been talked about and even shown in the sorafenib study. But I think that'll be interesting to look at from a toxicity standpoint.
So far, very few toxicities have happened. So we are not able to correlate them with dose. I mean, maybe in longer follow-up when we have like larger data available, then perhaps we can correlate with dose.
I agree that this is a very interesting study. So regarding the patients who presented amenorrhea, I'm curious, was treatment discontinued for some of them? And was the amenorrhea reversible, or you don't have those data?
So one of them had menorrhagia after amenorrhea. So otherwise, the amenorrhea is continuing. We are seeking this gynecological help. However, we haven't stopped treatment for amenorrhea. We haven't stopped the treatment for amenorrhea. One of them had menorrhagia. So one of them had menorrhagia after a few months of amenorrhea.
Okay, fantastic. I think we're ready to move along, but it's a really nice demonstration of a lot of the other effects of these treatments and Desmoid. So
thank you.
Thanks.
Thanks.